So as we wait for the last people to take their places, let me just welcome everybody here in the room and online and say a warm welcome to this first event organized by the Second Chance Association together with the Global Surgery Foundation and UNITAR, the UN's Institute for Training and Research. It's a first ever webinar, and my name is Juliette Linley. I'm a Swiss broadcast journalist, and it's my honor today to be your moderator here. We're here in Geneva, and we are looking at why it is so critical to include reconstructive surgery in the aftermath of conflicts and of catastrophes. Now, our aim here at the Swiss Foundation for Training in Surgery, which is hosting us here today, is to lay the groundwork together, collaboratively, to acknowledge the crucial role that reconstructive surgery is playing in restoring a person's physical, psychological, and social well-being. Now, these are individuals affected by humanitarian emergencies of all types, be they natural disasters, wars, or mass casualty incidents. Now, too often the world will focus on restoring and reconstructing countries, reconstructing the economies, but we really want to focus on reconstructing lives, human lives. Now, during this 1 hour panel, this 1 hour roundtable with our esteemed guests here and online, they are all international experts, and we're going to bring to the fore the challenges and the opportunities that are involved in doing just that. Now, you will all find a Q&A button at the bottom of your screen. Please send us your questions and specify to whom you would like to address them. Just a gentle reminder not to use the chat because that is disabled, but please do use the Q&A button. Now, without further ado, allow me to introduce our keynote speaker. He's the co-founder and he's the president of Second Chance, an organization that's been active for over 10 years. He's a consultant in plastic and reconstructive surgery here at the Geneva University Hospitals. Ladies and gentlemen, he needs no further introduction. Please give a warm welcome to Dr. 𝗕𝗰𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀
Thank you, Juliette. Dear friends, dear colleagues, first of all, I would like to thank Yelena Gocheva, Karine Decken, Anne Zaidan, Martha Eros, Julien Bosset, and all the persons who make this webinar possible. How the idea for this conference came about? It emerged in two stages. The first was during our mission to Nepal, following the earthquake a few years ago, where we worked on the reconstruction of mutilated people buried under the rubble. An article in front page of Time magazine, headlined Nepal's disaster, touched our eyes. It was written, reconstruction work has been slow in Barpak, a village at the epicenter of the earthquake. So we just opened Time looking for a picture for a reconstruction, an article on reconstruction of human, but it dealt only with the reconstruction of building, not individual. Next. As this photo shows, when a bomb hits a building or an earthquake destroys it, survivors are often left with mutilated body parts. Without intervention, as illustrated on the picture on the right, scarring can deform the body. It's crucial to understand that the reconstruction of people should go hand in hand with the reconstruction of houses. Next. Most of the time, this reconstruction cannot begin immediately. Surgeons have other priorities and are not specialized in reconstructive surgery. We have to wait until all the tissue have healed to guarantee a good reconstruction, which usually takes 1 or 2 years. Then the plastic reconstructive surgeon can intervene. Next. When you search on internet for terms like reconstruction in Syria, reconstruction in Ukraine, reconstruction in Ethiopia, the article and conferences focus solely on the reconstruction of building and the economic aspect. I am in the opinion that the urgent care of the wounded should naturally include aspects of basic plastic surgery, such as skin graft and the like. But first of all, human reconstruction should be included in international and political discussion and reflection on post-conflict reparation. Next. In the humanitarian cluster, the reconstruction often overlook the importance of reconstructive surgery. to initiate a discussion about elective reconstructive surgery following conflict or natural disaster. We, a small group of individuals, including surgeon and non-surgeon, engaged in humanitarian and development work, have decided to organize this webinar. We hope it will address some of our queries and signify the beginning of a series of in-person conferences leading to potential on-the-ground action. Thank you.
Thank you, Dr. 𝗵𝗂𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀𝗀 message of the UN's Assistant Secretary General, Mr. 𝗪𝗂𝗀𝗃. He's Executive Director at UNITAR, and he is the co-chair of the Global Surgery Foundation. Here is his message.
Distinguished speakers and colleagues and esteemed guests from around the world. On behalf of our team at the United Nations Institute for Training and Research and the Global Surgery Foundation, I'm very pleased to speak at this important event addressing the need for coordinated efforts on reconstructive surgery in post-emergency settings. Conflict, you see, is everywhere, and they are becoming increasingly prevalent and devastating, leaving behind a trail of destruction and human suffering. The impact of conflict extends far beyond the immediate violence, often resulting in long-term physical, psychological, and social consequences for the affected populations. Over the past 12 months, the international community has focused on the rising number of people directly impacted by the multiple converging emergencies, from health crisis and natural disasters to conflicts like those we see in Ukraine, Gaza, and Africa. A total of almost 400 natural disaster events were recorded globally in 2023, which cost the global community an estimated $380 billion in economic losses. Disasters such as the earthquake in Haiti or forced displacement such as the refugee crisis following the conflict in Myanmar have continued to pose significant challenges for humanitarian aid and emphasize the need to broaden humanitarian attention to other parts of the world. According to the latest UN figures, nearly 300 million people in 72 countries will require humanitarian assistance and protection in 2024. We often encounter these statistics in media coverage of disasters. Likewise, there is always an active dialogue about post-disaster or post-conflict reconstruction. This, of course, is referring to the country's infrastructure. However, what tends to be overlooked is the significant need for surgical care for the injured and disabled, long after the immediate aftermath of the crisis. The stories of those affected tends to be quickly eclipsed by the next headline. Roughly 15% of any given population comprises individuals with disabilities, but in protracted conflicts, this figure is known to be significantly higher. In Syria, for instance, at least 25% of individuals over 12 are reported to have a disability, placing a strain on healthcare systems and imposing socioeconomic burdens on their lives. Reconstructive surgery can advance 50 of the 170 sub-goals and 11 of the 17 SDGs, preventing death and disability by restoring and other functions. By incorporating reconstructive surgery into post-emergency planning, we can address the long-term needs of survivors who have sustained severe injuries or deformities. This means establishing surgical facilities, training healthcare providers, and securing necessary supplies and equipment well in advance of any future emergencies. Furthermore, such a priority sends a powerful message of compassion and solidarity to affected communities, the foundational ethos of the SDGs. In conclusion, on behalf of the United Nations Institute of Training and Research, I encourage those involved in today's discussions to boldly move ahead, breaking outside the status quo, and help survivors regain functionality, dignity, and hope in the aftermath of disaster, and through this pave the way for a more resilient and inclusive future. UNITAR, along with the Global Surgery Foundation, is committed to working alongside all stakeholders to help support answering this important need. Let us partner together in this effort, set our mind on the targets in front of us, maintain an optimistic spirit, and persevere in this important work to reach those who are furthest behind. Thank you.
Powerful words there from Mr. Seth. His comprehensive assessment of the global situation underscores, excuse me, the timeliness and the relevance of this important discussion in addressing our very pressing challenges. Now, I'd like to introduce you to the Dean of the Faculty of Medicine here at the University of Geneva. Please welcome Professor Antoine 𝗪𝗂𝗪.
Well, thank you so much for the opportunity, and I must say I'm really moved just not only by what we just heard, by the words of Dr. Quinaudot, but also by the fact that we are here in Geneva gathering those who actually not only think about reconstruction, but practice it, plan it, design the policies about it, train the new reconstructive surgeons, and do research about it. And I think that's a very rich ecosystem that we have. And so on behalf of the University of Geneva, I'm really proud to be part of this seminar. On behalf of the Geneva University Hospitals, I'm really proud to be part of this webinar. And I must say that one of the things that we have here at the Geneva University Hospital and at Geneva University that no other large hospital or no other large university has is the fact that we are in Geneva. And when you think about being in Geneva, it is about being at the epicenter, the center of gravity of multilateral governance in the field of health, in the field of humanitarian action, and also in the field of other domains that are related. And this is something very special, and I think we need to be aware of this. And I know that many of us are UNITAR, ICRC, Global Surgery Foundation, the Second Chance Association, that we are in a place where we can actually connect what happens on the ground, how we build the next generation of surgeons and of policymakers, interact with the hundreds of NGOs that are active in this place, and the international organizations that are active in defining policies and defining large programs. And so I think it's really important to understand that this is something unique, this is something we have to value, and this is something we have to build upon. And this is, for me, going to be one of the important outcomes of this webinar, and the thinking that goes around it is how can we leverage this unique capacity that we have here in Geneva to make sure that the vision that was presented to us can really be achieved in terms of reconstructing people beyond reconstructing buildings and the economies. And with this, I just want to say I'm excited to be here and look forward for the other presentations and the discussion that will follow. Thank you so much.
Thank you so much. Thank you, Professor 𝗪𝗂𝗪, for your very warm words and encouraging. Now, so what are the challenges involved in bringing reconstructive surgery to post-emergency settings? What are the specific difficulties that we can come across? Now, at this point, I'm going to bring in Dr. 𝗕𝗂𝗀𝗀𝗀𝗀𝗀. She's a consultant surgeon at Sheffield University, and she's joining us from the UK. Please welcome Dr. 𝗂𝗀𝗀𝗀𝗀𝗀 online. Hello.
Hi, thank you, Juliet. The challenges we face are vast and variable, and well beyond the scope of a short talk. So what I'll try to do is just outline what I think are the major areas within this. If we can look at the next slide, please. Yeah, so the major areas are outlined on this slide. It's what is required, why is it required, what should be provided, and who should provide it. Next slide, please. So in the first instance, what is required? Well, we need to accurately estimate the burden of disease and disability that will require reconstructive surgery in a setting such as a post-conflict setting. And what I mean by that is that we need to know the number of people involved, the demographics, the severity of the injuries, the type of injuries, and the location of the population affected. We need to bear in mind that the disability can often be hidden. It can be ongoing, and without timely treatment, the disability can continue to get worse. We also need to understand why we need to do all of this. What is the impact of disability and disease on the individual and on society? Firstly, looking at the individual and the individual's family, there's a physical, emotional, and financial impact, and this can be considerable. We have good data from Gaza in post-war amputees showing that the levels of pain and psychological distress is related to the level of unemployment and the level of financial struggles they have rather than the actual severity of the disease. We have similar data emerging from post-conflict populations in Cambodia, also showing high levels of psychosocial distress, long-term discrimination and stigma. Additionally, what makes their financial struggles worse is the fact that often family members become unpaid carers, and we see this in other conflict regions as well. Secondly, looking at the impact of this on society, on the country, we can look at disability-adjusted life years. And if we look at the data from 2019 from the WHO, we can see that almost 7 million Dalis globally are accountable for conflict-related injuries. And if we take into account recent conflicts, I'm sure this figure will be much higher. If we zoom into the WHO Eastern Mediterranean region, where quite a lot of our current conflict regions are situated, conflict-related injuries are within the top 20 causes of Dalis. And if we zoom in even further and look at individual countries such as Afghanistan or Syria, we find that conflict-related injuries are within the top 3 causes of Dalis. So it does have a significant impact at a country level. And this has a financial impact as well, and that can be direct, indirect, and intangible costs. So as an example, in the Netherlands, hand and wrist injuries cost about $740 million per year. If we look at work injuries, 4% of the global GDP is accounted for by work injuries, and that's the cost of it. So we need to actually estimate what the GDP cost is in terms of conflict-related injuries. And as you can imagine, it would be higher for some countries than the others, but we do need figures on that. Next slide, please. So what should be provided? Well, we need to allocate our resources appropriately. In the first instance, we need to identify the residual capacity of the conflict region in terms of providing such services. And then we need to calculate the additional cost of providing a comprehensive service, and that would include infrastructure, equipment, a well-trained anaesthetic and surgical workforce, and allied health professionals. And we need to be able to implement and deliver this full service. Next slide, please. Sorry, can we have the next slide? Oh, sorry, we do have it. Finally, who should provide it? Well, we must have the right people. And what we really need to do is, as we know, in any conflict region, there are often multiple stakeholders involved, and we need a coordinated approach. Again, we have data from Gaza showing that if the approach isn't coordinated or the resources are not appropriately allocated to the appropriately trained people, the disability can often get worse and get to a stage where it becomes very, very difficult to treat. So we do need to look at who is going to be managing the services. And finally, we need to be continuing with ongoing appropriate outcome assessments to evaluate the effectiveness of the resources that we have allocated, to make sure that the population is being served and the needs are being met. On that note, I'll pass on to the next speaker to tell us a little bit more about that. Thank you.
Thank you so much. Thank you, Dr. Kundahar, linking up for us from the UK. Now, how can reconstructive surgery contribute to post-emergency recovery and rehabilitation? That's the question that we're going to ask Dr. Barakia Takliti, a consultant surgeon at Addis Ababa School of Medicine, and he is joining us from Ethiopia. Welcome, Dr. Atakliti. Hello.
Thank you so much. This is I go a little bit to the situations in regard to conflict. They are complex in nature. That is, have a component of psychological, social, and economical problems. And if you see the pattern of survival versus mortality in conflict, so many people, they survive. About 16-to-1 ratio, 16 people would survive against 1 people dying from 1 person dying from conflict. And these people have a certain African community. I'm talking about Africa. And the community structure in such a way that we have a horizontal and vertical extension. Parents, grandparents are living in a family, and also aunts and nephew and cousins also will be in a family, and only few people are earning the bread. So whatever is happening to that particular individual is causing a lot of problem, like kids will not go to schools and grandparents wouldn't have anything to eat. And what
I'm sorry about the quality of our link up. Dr. 𝗪𝗪𝗠𝗃𝗃, are you with us?
now, at least in Africa, is we are focusing on saving. Can you hear me? Hello?
Yes, go ahead. Go
Hello?
ahead. Go ahead.
And rehabilitative program is not really sophisticated. It's just the general health service system can help us introduce a reconstructive surgery. Next slide, please. Next slide. Next.
Go ahead. Yeah, we're on the next slide. Go ahead, Dr. 𝗪𝗪𝗠𝗃𝗃, can you hear me?
Next slide. Yeah, if
Yes.
you have a good program, we can have
You can go ahead. We're on to the
long-term
next slide.
recovery. And the most important thing is the socioeconomic. Yeah, the socioeconomic integration is very important. If you have a good setup, this is going to also bring development. It also reduces the surgical disease burden of the community. We have legislations recently, WHO last year adopted and endorsed the importance of rehabilitation, a rehabilitation program being integrated into the general health service system as part of the universal health coverage. This is a good thing. I strongly believe that reconstructive surgery or rehabilitative surgery should be a pillar, a strong pillar, one of the pillars in the general health service system. Next, please. Next, please.
Yep, go ahead.
So we have so many legislations. For example, in Ethiopia, there is an inclusive legislation on inclusiveness that was probably 11 years back, but it's not adequate. As long as we don't take it further, having legislation doesn't take us anywhere else. And reconstructive surgery, unfortunately, though it is very important for African community with a lot of conflict and also natural disasters, it has become an orphan in the health service system. So we need to integrate this preparedness training, particularly in our residency program, economic integration of our patients, and also significant psychological lift up would be seen, which ultimately would be translated into the development of the community. So my last message is reconstructive surgery should be mainstreamed and nations should sign a convention. Thank you so much.
Thank you so much, Dr. 𝗪𝗪𝗠𝗃𝗃. What a great message to end your link up from Ethiopia on. And thank you so much. And now, when delivering effective reconstructive surgery in post-emergency situations, now what are the key points that need to be taken into consideration? Well, I'd like to bring in Dr. Amanda Guzman. She is professor of plastic surgery at the University of California's San Diego School of Medicine. Joining us from the United States, please welcome Dr. Guzman. Hello, Amanda.
Hello, can you hear me okay?
Yes, perfect.
Wonderful. Thank you so much for the opportunity to join the webinar. If you want to advance the slide, I'd love to share for just a few minutes about perspective on how to be most effective. And I think that this is a really important topic, and congratulate Pierre and the entire group for bringing it to the attention of many. In terms of reconstructive surgery, there are many components of really getting an optimal result. When you look at post-emergency situations and a lot of the injuries that occur, the treatment of those injuries is definitely critical to be led by a surgical team. However, the ultimate outcome from those surgeries really depends on a multidisciplinary collaboration to get an optimal result from that reconstruction. And what that means is, although there may be limb-saving surgery after someone is involved in a traumatic incident, the ability to fully recover from that reconstruction also depends on us building a team of stakeholders that will be able to engage in the long-term management and rehabilitation, including physical therapy, occupational therapy, and wound care, scar management from burns. Those are things that, although surgically really helps to jumpstart the recovery, that we work best when we're really able to provide long-term longitudinal management to make sure that we can help these individuals restore their functional capacity and improve their quality of life. I think this is one of really the magical components of reconstructive surgery, because we do function best in a team, that we are by our nature builders of teams, and involving stakeholders from all of these different allied specialties to optimize the delivery of care in post-emergency situations will certainly impact the quality of life of the communities and the individuals that are victims from conflict. And this will ensure that they are able to optimize their functional recovery, as well as the social and psychological recovery that is necessary from these devastating situations. And ultimately, that has tremendous implications for the strength of the community. The key considerations for building these multidisciplinary approaches under surgical leadership are to identify stakeholders and leaders from each one of those groups, and to also have a ripple effect from developing this team-based approach, so that it's not only addressing just the immediate conflict, but longitudinally helping to create the infrastructure that's necessary to strengthen surgical systems. And when we look at doing complex reconstructive, for example, such as microsurgical reconstruction, which is something that we have engaged in a number of different parts of the world in post-conflict situations, such as in Ukraine, we're able to leverage those opportunities to really strengthen the care that's provided by our anesthesia colleagues, by our nursing colleagues, by the rehabilitation specialists that are required to allow individuals to be able to ambulate and to restore their functional capacity in the workforce. So I think that in addition to really jumpstarting the recovery, we have a lasting effect of building a team-based approach that will strengthen surgical systems in the individual locations where we're able to really provide these services. In addition, because we are a global community, we have been able to leverage resources both regionally and virtually to strengthen these types of complex reconstructive services that really increase the quality of life for individuals that are victims of conflict. For example, again, for microsurgical reconstruction, which is something that can allow us to save someone's extremity so that they can walk again, that we have been successful in being able to teach a lot of these skills in a virtual platform. And that allows us to really leverage that global community and regional community, again, in a very much an education-focused health system strengthening approach. And ultimately, I think that the critical component of managing it, our success, is measuring it and looking at the outcomes that our patients and our communities will benefit from by these interventions, and having quality improvement processes that are built in so that we're very closely tracking our outcomes is critical to the success of building this infrastructure and really looking at longitudinal recovery from devastating traumatic situations. So thank you very much, and look forward to the discussion on this topic.
Thank you so much, Dr. Gosman. Indeed, so important to track the outcomes. Now, a quick reminder, if you want to send in your questions, please use the Q&A button at the bottom of your screens. And now let's move on to how do we leverage these approaches in a strategic manner in order to promote the development of strong surgical systems across the world and in affected regions. Now, Dr. Tom Potokar is right here to tackle that. He's the ICRC's chief surgeon and an expert on burns. Welcome, Tom. Thank you.
Thank you very much, and good afternoon, everybody. First slide, please. So I'd like to just really talk a little bit about the strategic approach, if you like. And we've heard the term system strengthening several times already from the previous speakers. And this is at the core of really having a sustainable approach. If we look at what we mean by system strengthening, well, these are the building blocks that contribute to an effective surgical care system. And this includes the infrastructure, the workforce, service delivery, financing, information management, and governance. And I think if we look at each of these in turn, we can see how and what we need to do to help to improve the reconstructive surgery and rehabilitation for those disabled and disfigured by injury. So in terms of leadership and governance, well, those in the leadership position need to understand the issue and they need to understand what the solutions are. So it's important that those in that position do have the knowledge and experience, and if they don't have it, that professionals with that knowledge and experience are able to advocate to that leadership why it is so important to have access to reconstructive surgery. In terms of service delivery, we need to look at an integrated care approach, so from the point of injury through to reintegration back into society, and that also includes obviously access to care. Financing is always, underpins everything, and the financing needs to be both adequate but also dedicated specifically to this process. The workforce needs to be developed because across the globe there are still far too few specialists working in this field. Many countries have plastic surgeons in the figure of one hand, maybe 3, 4. Some countries have 1, some even less. And of course, the other specialties, nursing, rehabilitation, etc., that contribute to this. The products, well, this includes obviously kits such as surgical kit, but also rehabilitation kit, prosthetic equipment, etc. And then information systems. We've heard several times from our previous speakers about the importance of outcomes, and we need those information systems to be able to collate these outcomes, to be able to audit and see that we are achieving what we need to achieve. Next slide, please. We need to focus on continuity of care, and that's really looking from the point of injury right through to rehabilitation and reintegration back into society. Integrating this approach into each of the building blocks when we're planning. We've heard about the importance of the biopsychosocial impact, so we also need to look at biopsychosocial outcomes, not just purely anatomical or length of stay or these kind of outcomes. We need to link these health outcomes to disability and link that to the economic and social problems, and some has already been done. And we heard from our first speaker about how this has been done in for example, in Afghanistan and 1 or 2 other countries, but both for the individual and the state. And we also, because finance is so important in underpinning all this, need to assert how these integrated systems are more cost effective, and that relates to the value of the outcome compared to the expenditure, and also more cost efficient. In other words, how the provider uses their available resources to supply goods and services. And I think finally, if we look at the Lancet Global Commission and WHO 6 indicators for quality in surgical systems, there are really 3 themed areas. So preparedness, delivery, and effect. And this is around access to timely surgery, around the specialist surgical workforce, the surgical volume, the mortality and morbidity, and protecting against impoverishment for patients. So I think all of these are really very important factors that we need to advocate for at a very high level to ensure that the policy changes that are required are put into effect. Thank you.
Thank you, Tom. And I'd like to now open up the discussion to our panelists. We've had so many questions coming in. Thank you so much. All around the world, they're sending in their questions. And I'm going to start with a question that they've sent in for you, ภิère Kinodo. And this is what they're asking. It's like, why do you think reconstructive surgery isn't more developed in post-conflict situations? And who do you think should be involved in developing those post-conflict reconstructive surgeries?
In fact, it's quite unique because I think personally, you have 2 levels. You have like a war or an earthquake, you send surgeon, emergency surgeon. They are general surgeon. They have to save life. They are not fully trained in reconstructive and plastic surgery. So they go, they can do skin graft. I speak a little bit technical, sorry, but it's important to understand this. You have this surgeon, but they don't have this training to be trained as reconstructive surgeon. It's like you have to start with general surgery, then you have a long training in plastic and reconstructive surgery. Then you go, most of people, of plastic surgeons go in private practice. They have the skill, but they don't go if there is a war. They don't go, they are not part of it. So you have two teams. And I think one of the goals should be link those two teams together, that to have a continuity, and that, I don't know what Antoine, could you have any solution? I think how can we treat the wounded long time after a conflict? If you have knowing your knowledge of the international community, medical field, what would you have as an advice?
Well, I think part of the advice was already given, talking about the continuity of care. I think that's a very important thing. As you said, there is quite a delay between the acute phase, where you have to bring in more like trauma surgeons and other kind of skills, and then the time it takes so that you can be ready starting doing the reconstructive work. And then what's also important is all the follow-up and the documentation and the evaluation. So I think, you know, if you look at the whole continuum, you need first to start to have trained people, and then to be able to deploy them. We heard also from other interventions the importance of having teams able to work together, because it's a complex teamwork. And for all this, you need to have information that is supplied. You may have to be able to access remote expertise, and as you know, digital tools can help also in connecting different experts remotely, so that you bring the right expertise where it's most needed. And then the whole issue about documenting what has been done, what is the impact, the follow-up of the patients, all this needs significant coordination. So if your question is, you know, what does it take? It takes a lot of different efforts and a lot of coordination. One of the questions that we may want to ask is, you know, how can we facilitate the establishment of this coordination so that when there is a need, you can gather the right resources to actually bring the right people, the right tools, the right information to make the most of the intervention. So that's one of the aspects. And then probably the other aspects my colleagues are better suited to talk about, in terms of policy making, in terms of regulations, in terms of best practices. All these issues are also very important.
Thank you. And I just wanted to add something important. Now the war, you count the dead. You see on the news every day, we say how many dead in this country. So the weapons and the soldier now try not to kill. And they shoot in the legs, for example, and then you have many mutilated people. They are not dead, but they are mutilated, and the treatment will be long and can only happen 1 or 2 years after everything is healed. Then you can reconstruct. And we would like to raise the awareness of the political society, of the United Nations, to recognize this as a matter of fact.
Yeah, I'd like to bring in 𝗂𝗲𝗯𝗶 here at this point. How would you define the post in post-conflict or post-disaster terminology? 𝗂𝗲𝗯𝗶, can you hear me? Are you there?
Yes, I can hear you. I can hear you. Excellent question, Juliette. I fear, however, my answer may not be so excellent, as it's quite a difficult thing to define, to be honest. And I think probably best conceptualized as a transitional period between, boundaried by the period which is a post-war and, past war and future peace. Now, in reality, it's not so simple, and it's often difficult to define when exactly the war ended and when peace started, if it started at all. So it becomes very, very difficult. And then when you look around us, conflict can go on for weeks, months, years, and they can be low levels or no level of conflict. And on top of that, acute escalations. So trying to define when we start the post-war period is very, very difficult for all. For the purposes of reconstructive surgery, I think we need to think about basically a period where we can safely and effectively implement a reconstructive surgery that meets the needs of the population of that region. And we need to think about that transitional period where we have to link kind of support and resources for that kind of early period, but also link it to long-term rehabilitation and sustainable development.
Can I bring in Dr. Gosman at this point? Amanda, you're there. I'd love to know, can you give us some specific examples of successful multidisciplinary teamwork that you've experienced in reconstructive surgery? We have one viewer online who's asking about that. And can you give us an idea of that?
Absolutely. I think, I really conceptualize this in two different ways. One is the role of the reconstructive surgeon within the other medical and surgical specialties, and then the effectiveness of doing reconstructive surgery in terms of the long-term follow-up that's frequently required. So to address the first one, I would say that, a lot of times in areas of conflict where the initial trauma stabilization may be done by our orthopedic or general surgery, trauma surgery colleagues, that many times the optimal result from those injuries, although there is initial stabilization, the optimal result from those injuries really depends on having collaboration with reconstructive surgery. For example, for open leg fractures that have the need to have bony stabilization and treatment of the actual fracture, frequently in areas of conflict where there are explosives and significant contamination, the ability to get that bone and that fracture to heal depends on being able to have adequate soft tissue coverage, which is where the reconstructive surgeon is able to assist by creating an adequate debridement, by being able to provide that skin or muscle coverage over that broken bone so that the patient can actually go on to healing. So I think we need to rethink a little bit the way that we go beyond that initial stabilization of traumatic injuries so that we're really completing the treatment and getting to the point where we're really focusing holistically on the patient and their recovery. In that same example, there are needs for additional skills acquisition and in areas of conflict where sometimes the traditional kind of approaches for reconstructive surgery aren't adequate to address the complexity of the need, then that's really where we can leverage some of our global community and educational resources. And especially during COVID, we've really expanded a lot of our virtual training. We have some virtual networks and educational fellowships that occur worldwide where we have been able to assist with skills acquisition for more complex reconstructive, such as microsurgery, and to the point where we have mentored surgeons who have encountered patients that had devastating injuries, such as a nearly severed limb, that those surgeons were then with virtual training able to reconnect some of the circulation to that limb and really save someone's extremity and be able to restore their function. Ultimately, their ability to walk and use those extremities depends on collaboration in a team and really leveraging our ability to utilize rehabilitation, physical therapy. And those are things that really take a long time and are much more difficult to provide longitudinally and quantify, as they're very specific to each individual patient.
Yeah, thank you for that, Amanda. Tom, I think you wanted to come in. Can you just grab the microphone? Perfect. We have a lot of questions coming in. I don't know if we're going to have time to address them all.
Yeah, I just think it's important that we think of reconstructive surgery as a process rather than an operation, let's say, and that I remember years ago, rehabilitation was considered as what happens after the patient is discharged. And now we know rehabilitation starts on day one when the patient comes into the hospital. And in many ways, it's the same with reconstruction. So there is complex, highly complex procedures that do need to be done by very specialist plastic reconstruction surgeons that are often down the line, as we've heard, dealing with later complications. but it's really important as well that the initial phase, and talking about the the Lancet Global Commission with 6 indicators, one of them is around access to timely surgery, and there they have 3 so-called bellwether procedures, and that is access to have this management appropriate, and one of those is open broken bones with soft tissue. Initial management is so important because that is not done appropriately. Then, and I've seen this in many countries around the world, it's then that you get all the delayed problems that require much more complex reconstruction later on. And as Pierre said, it is difficult to find people to do this type of work. So part of our process has to be to train people in some of the more simple procedures, and plastic surgery, unlike other surgical specialties, is really based around technique. It's not based around an anatomical area like a bone or the brain, or it's around technique. So some of these more basic techniques, we really need to make sure that people understand the right approach to managing these, and this what we call the orthoplastic approach, for example, in managing limb injuries, which starts from the point of injury.
Yeah, I'm just going to move it along. We don't have a lot of time left. We have a lot of questions coming in, but Pierre, one recurring question is they're asking, how can they contribute to your vision? I have people saying, like, what can we do? And are there trainings that you're offering? Or how can people around the world who are now linked up to you, how can they contribute to what you want to do?
This is why we have this webinar, in fact, to find solution. And I think in Geneva, we have United Nations, you have UNITAR, we have GSF. We could get together and to make like a consortium, let's say, like call us and we'll try to find a solution. Either you can imagine to get linked with International Society of Reconstructive Surgery, to have some volunteer that can come, and even pro bono. That's what could be a solution. Another solution could be, as Tom was saying, to teach basic skills to people going on the field, and try to get everybody together, try to raise the fund, to raise the awareness of the political people, and so we can treat all those wounded people who are left behind. I don't know what Geoff, Jeff, what is your will be your advice and your proposal, because you're really we really need your input into this important matter.
Well, thank you very much, and that is a tough question. How do I get involved? You're already in your practice and you see the incredible need, but how to get involved? And it really comes down to joining organizations, consortiums, as you may say, that are already doing that work, because it's very difficult just to go out on your own and try to figure this out. There's a lot of problems associated with that. And it all comes through partnerships, long-term partnerships, long-term relationships with the people on the ground in particular. And so in terms of those listeners that are thinking to themselves, what can I do? How can I get involved? What I would suggest is that you get on the mailing list of certain organizations like Second Chance, like the GSF, and keep informed about what the opportunities are. ICRC is also another great organization, which I've also worked with, that has opportunities for specialists to participate, clinically speaking. And then it comes down to the partnerships, identifying this consortium that you're envisioning. It's a great idea, but then that has to be anchored in a place like the university, in partnership with the UN agencies, the international agencies. And through that consortium, identify key locations where we can build capacity. If we just parachute in and then leave, yes, a few patients have been helped, but we haven't really made a big difference for sustainability. And one of my favorite stories, if I may, is 24, 25 years ago, I had the opportunity to work in Nepal, and I had the opportunity to train some medical students, Nepalese medical students. And I had then the very great privilege of fast forwarding 20 years, going back and working for one of my students. He was my director. And that is what we should all aim for. Working ourselves out of those parachute jobs and building capacity on those front lines. And one of the things that I've seen far too often in conflicts, like the Nepal earthquake, is already in these circumstances. And we see it in Haiti and in Gaza and all these low resource settings. Even before the disaster happened, their resources are already scarce. Their resources are already stretched to the maximum. Tom, you were saying that, I think it was you who were saying that in some of these countries, there's maybe one surgeon, maybe none who do plastic surgery. And so this is where we can start building capacity, because when the disaster happens, then there's a surge of need. And in this particular story of reconstructive surgery, it's not necessarily the race in and the emergency damage control, but you have time to build that capacity, work with the local surgeons and do the training. And that's where the partnerships with organizations like UNITAR and GSF and Second Chance really become powerful because the training is there. I'll stop there because there's a lot more we can say about that, but
there's a lot more to be said on so many things. And I have a question coming in regarding UNITAR, and it is, the person is saying the consequences of physical destruction caused by conflicts and disasters cannot be denied in the humanitarian world. We're often faced with challenges in the resources needed when we need a system, and we need a system approach. Now, what role can UNITAR play? I mean, apart from providing training. Perhaps the gentleman here can tell us your name, please, and give us an answer for that question.
Thank you. My name is 𝗪𝗂𝗀𝗃. I'm the director of UNITAR and the officer in charge now that Mr. Seth is somewhere else. Let me address what you say and the question, what role can we play?
Can you do me a favor and look into the camera so that they can
I'll be happy to do
answer?
so.
Thank you. Perfect.
But before I do so, I just wanted to echo Pierre and Jeff on something that they say. If you are listening and you have a passion and a heart for this thing, please volunteer. I'm speaking on behalf of the United Nations organization. We need you. You can make a difference. You just heard an anecdote of someone that went to Nepal, taking one sabbatical, came back 20 some years later to see the results of his efforts. So please do so. What I wanted to mention on behalf of UNITAR is that the role that we have as a UN agency should go beyond training. That's the obvious. And here you have a beautiful organization called the Global Surgery Foundation, led by Dr. 𝗍𝗂𝗀, that is making a difference. But I also need to mention something on behalf of the UN. There is something called, Pierre mentioned it at the beginning, perhaps the most important slide for me, the system behind a humanitarian intervention. You remember that round thing? Reconstructive surgery is missing. And I simply wanted to ask everyone to think why it is missing. It is missing because there is a person behind called the senior humanitarian officer. For the case of Gaza is Dr. Kass. If you ask her, why is it that reconstructive surgery is not there? The answer is very simple, competing priorities, right? But then someone has said before that there should be a measurement, metrics behind the outcomes assessment. If you actually have the statistics of how many people need this thing, she will immediately say, this is needed. So all in all, what I wanted to say, and UNITAR can help you there, is that we still need, I've been a diplomat for more than 20 years, and I can tell you that I have never heard what I heard here today. Thank you, really. Because we still need to recognize in multilateral organizations, in multilateral diplomacy, the need to focus on this. There is too much suffering, and we are not seeing it. We have to talk with every humanitarian coordinator in every conflict, so to tell him or her, this is important, and UNITAR can help you beyond training. Thank you.
Thank you so much. Thank you. Pierre, would you like to add something? Do we have time for one more question? We have time for one more question or one more comment. Does any of you have a comment, or should I read one of the other questions that have come in?
I think the point that was just made from UNITAR is really enlightening. I mean, we really need to avoid having to go to each of the stakeholders and explain them those issues. I think it's important to have numbers, it's important to have knowledge, but it's also important to have mechanisms to share these. And again, going back to coordination, not only logistical coordination of organizing missions and care, but coordinating the elaboration of knowledge, the sharing of knowledge, the policy making is something that I think is going to be very important if we want to raise the awareness and make sure that in the round thing there is something about reconstructive surgery. And I think that's something we can do here in Geneva in collaboration with the international organizations, with the NGOs, with the academia, with the healthcare professionals, because we need all of them to work together and find ways to actually build this. And maybe it's time that we get our acts together and try to build something that can help moving the agenda of reconstructive surgery forward.
Oh, one more point from Tom. And then...
Yeah, no, just to reinforce as well, I think the messaging is really important. Now, a lot of us here, and I'm sure many on the call, are aware of what we mean by reconstructive surgery and are aware of what we mean by plastic surgery. But I can tell you that the bigger, wider world out there does not. And the number of times I've heard people say, why do you need plastic surgeons in a conflict? Are they going to be doing, you know, rhinoplasties and implant? You know, there's a real issue of a lack of understanding about what reconstructive surgery is, what it can offer, what it can achieve. So I think it's important as well that we look at how we get the messaging across and maybe think about some of the terms we use and to make it more accessible to people so they really understand.
Such a good point. So important.
Yeah, thank you very much. Exactly.
Okay, I think we are going to have to wrap it up here. And I promise you that if you've sent in questions, they will be answered by email, every single one of them by the experts, and you will just say to whom you are addressing your questions. So let me hand over for closing remarks to Dr. Jeff Ibbotson. We've heard from him already. He is Executive Director of the Global Surgery Foundation. Go ahead, Jeff. It's on.
Thanks. And I'll just stay here instead of going to the podium, if that's okay. I just want to summarize a few take-home messages. You've heard a lot of very powerful ideas today. And I was just taking notes as we were having this discussion. I just want to share some of these with you. Nikhil had mentioned that in his speech, his video speech, about the importance of incorporating reconstructive surgery into the post-disaster planning. And so this is one of the elements that we've mentioned a few times. If it's not already incorporated into the planning, of course it's going to get missed. So this is an important element, one of those bullet points you want to put on your next steps. But I would take it the next step forward, even before the disaster happens and the disaster planning, to have reconstructive surgery capacity building built into a nation's health plan. Now, there is something called the National Surgical Obstetric Anesthesia Plan that a lot of countries, and particularly in sub-Saharan Africa, are doing. Pakistan has done one. There's Western Pacific Islands are working on it. And that is a surgical plan that is integrated into the national health strategy. If you can get reconstructive surgery as a key element in these plans to begin with, because many of these countries don't have any reconstructive surgeons, then that's your first baby step forward for capacity in the normal times, so that when a disaster does happen, an earthquake in Turkey or Nepal or a conflict, then you at least are starting with something. And those are the people who stay. Those are the people that don't have to come home to our day jobs, so to speak. They stay. And if those are the ones we really need to start focusing. I know Second Chance really works hard on building those local capacities. So I just want to make that as a one point. And the reality is the normal capacities, as I mentioned, they're already almost overwhelmed. And when a disaster happens, they're completely overwhelmed. And that's when support is needed. And this is where the post-disaster planning becomes very important in integrating how are you going to supplement that already inadequate capacity with more from external. And groups like Second Chance or ICRC are great examples of that. Something Amanda said, which really stuck out, and I want to reemphasize, is the multidisciplinary team-based approach. It has to happen that way. It can't be just surgeon coming in and doing the work. It has to be that multidisciplinary approach and other specialties right from the very beginning. I like what you said, Tom, about rehabilitation starts from the moment the patient goes in through the front doors of the emergency. Even before they have surgery, rehabilitation starts. And again, system strengthening. We heard a lot of really great slides on the system strengthening approach and the partnership approach. So that's a real strong take-home message. And finally, in the framework of global health, of the global health ecosystem, and Antoine, you referred to, we're in a very unique place here in Geneva, International Geneva, and all the agencies that have their headquarters here. It's a very key opportunity. Partnerships within that ecosystem are critical to making this successful. The other element of that is financing. Now, if you look at global health financing and you look at surgical care, not just reconstructive surgery, but all of surgical care, it accounts for a full third, 30% of the entire global burden of disease. And yet only 0.1% of global health financing goes towards building up surgical care systems. I'll say that again. A third of the global burden of disease requires surgical care, and yet 0.1% of global health financing goes towards building it up. We have to change that. And that's part of the key to what you're wanting to do in terms of reconstructive. So I'll finish with this. What are the next steps? It's very nice to have a great webinar, have this wonderful, very stimulating conversation. But I challenge all of you and you online, what are the next steps? What are we going to commit to not just go home and say that was very nice, and but to actually make concrete, tangible forward movement in this? And I think partnerships is the first thing. And getting those interested parties, those champions of making a difference together to start brainstorming to what that next step is. So don't leave it just that as a nice webinar. Get involved and make a difference. And I'll finish with that. Thank you very much.
Thank you so much. Thank you, Dr. 𝗃𝗃𝗀𝗃. Thank you to all of you for joining us from all around the world. It's been so encouraging to see so many messages coming in, so much a desire to participate, so much of a desire to be a part of this change that Second Chance is trying to implement all together by partnerships. As one of the people here said, please volunteer as well. And do us the favor, there's the poll at the bottom of your Zoom settings. Please take part in it. Please fill it out. Do us a big favor. And we will answer the questions you've sent in via email. On that note, thank you to all of our participants here in the room and online. Thank you to everyone. It's been a pleasure being your moderator today. Thank you from Second Chance and from all of us. Have a great evening.